Good afternoon, everyone. Thank you so much for joining today's webinar. Today we'll be discussing the EASL 2025 Hepatitis B Guidelines, which were just recently released and updated. We will be talking about key updates. We'll be talking about the lived experience and implications for lived experience, and we'll also be talking about the clinical implications for these. Before we get started and jump into today's session, I'd like to just go over a few housekeeping items and share how you can participate in today's session. To participate, all attendees will be on mute. You can participate by using the chat feature. We'd love to hear from you and know where you're calling in from today, so please feel free to introduce yourself using the chat. You can also use the chat to ask questions to the audience members, or you can also use the question and answer feature. There will be specific sessions in the webinar today that will focus on question and answer, so we'll be sure to direct you to use that when that time comes. Also, for your information, this session is being recorded. We'll be sharing to all registrants the recording of the session and the YouTube recording and its slides following the webinar today. Just a little bit about the Hepatitis B Foundation, which is hosting the webinar today. The Hepatitis B Foundation is a nonprofit organization that's dedicated to finding a cure and improving the quality of life for those affected with hepatitis B worldwide. The commitment that we have at the foundation includes funding focused research, promoting disease awareness, supporting immunization and treatment initiatives, and serving as a primary source of information for patients and families, the medical and scientific community, as well as the general public. Some of our specific programs at the foundation include outreach and education, public health research, policy and advocacy, as well as education and training. Just to share a little bit about some of the topics that we'll be covering during today's webinar, we'll be provided an updated overview of the new guidelines from EASL by Dr. Marcus Kornberg, who helped lead the effort. We'll be hearing from voices from the community and the implications of lived experience for hepatitis B guidelines. And we'll be hearing from Dr. Thomas Tu, Dr. Sue Wang, and Dr. Sherry Cohen during that time. And then we'll finally be hearing from Dr. Patrick Kennedy, who will be discussing clinical insights and case reflections for the guidelines and how they can be practically applied in practice. There will be then a time for audience question and answer, and Dr. Sherry Cohen will be providing closing remarks at the end. So at this time, I would like to welcome Professor Dr. Marcus Kornberg, who's the Deputy Coordinator Hepatitis Research Group Leader at Hanover Medical School. He's the clinical director of the Helmholtz Center for Infection Research and the co-director of the Center for Individualized Infection Medicine, and he helped lead the updated EASL guidelines for 2025. And we're honored to have him here today to share about the key implications for the updated guidelines and clinical considerations. So I'll pass it over to Professor Dr. Kornberg for sharing with us the update.
Yeah, thank you very much. I hope you can hear me. Give me a sign, okay? And
yes.
Slides are okay. So thank you very much for giving me the opportunity here to also discuss with you the update of the EASL Clinical Practice Guidelines on hepatitis B. Here you have the QR code. You can download the guideline also on the webpage of the Journal of the Hepatology. Just I would like to start my talk with some insights how we developed the guidelines. It was a long process, and here is a panel. And this was a privilege to coordinate this guideline with this excellent panel. We had representatives from all over Europe, starting in the north with Patrick Kennedy, is also with us today, Maud Lemont, who is also an expert in the issue of hepatitis B in Africa, which was important for us also to get some insights not only from Europe, but beyond. And this was also the reason why we included also Grace Baum from Hong Kong to have also insights from Asia, the Asian perspective. So then we move here to France, Barbara Testoni. She's an expert in virology, and this was important for us to discuss also the biomarkers like the HBs antigen quantification, but even discuss novel biomarkers like core-related antigen HBV RNA. Sabela Lenz, now in the governing board. At that time when we started, she was not in the governing board. She was a representative from Spain, also an expert in hepatology. From Italy, Pietro Lampertico, he was the chair of the previous guidelines, therefore he was still in this guideline to have the bridge from the previous panel to this panel. Francesco Russo, he has an expertise also in transplantation, and it was great to have him on board, but he was a representative of the EASL governing board. And Jerzy Jarozovic, he was a representative from Eastern Europe, and this was also important for us to have the Eastern European perspective here. He is located in Poland. And with me, Lisa Sandmann was helping coordinating this guideline process. Now, in addition, we had some advice from other colleagues, for example, Thomas van Wollechem and Dieter Glebe. They helped us with the chapter on prevention of HBV infection, the vaccination, where they have more expertise, and it was really grateful to have them also as panel members just for this specific topic. Now, what was the process? So we started the whole process in June 23. This was a kickoff meeting at the EASL Congress in Vienna. And then we had defined PICO questions. So what are the topics in the guidelines? And as you can see, we have the whole range of the hepatitis B covered in this guideline. And then we had monthly panel online meetings, Zoom meetings, which was very convenient. So, but we had also face-to-face panel meeting. One was in Frankfurt, which was very helpful to really fine-tune the PICO questions and the first recommendations we wanted to highlight here, especially on the indication, which was the most important topic in this guideline, I would say. Then we had the first Delphi rounds in November, December 23, where we really finalized the PICO questions. And then there was a second Delphi, so you can see our method was a Delphi method, not this evidence-based method, what we can discuss it, what the EASLD is using. So we had a Delphi panel a process where we then voted on the recommendations. And this was done, here you can see several times until we had a full consensus in the end. We had already a consensus for, I think, all of them after the second Delphi, but then we fine-tuned them to have also stronger consensus for several of the recommendations. And then finally, we got an external review. And then at the EASL Congress in Amsterdam, we released the guidelines. The Delphi panel consists of 51 colleagues from different areas, also in Europe, also beyond, and also patient representatives, which was that was very helpful, I think, for us. And we had also conversation with Sue here. She's also here with us today to discuss some issues which may be relevant and we may also discuss today. As external review in the end, you can say, David, you see it, David Mitume, Alessandra Mangia, Heiner Wedemeyer, and Rachel Zhang. Rachel Zhang was very helpful also during this process. She really looked at every single reference we had included here and did a great fact check. I don't know how she did it, but that was really helpful. And this was a really great work from Rachel. I have to acknowledge this here. Now the content, you can see that is also new, that we included some different topics here in this guideline compared to the previous guideline. For example, this topic on prevention of HBV infection with the recommendation on vaccination. But overall, you see the guideline content is from screening and diagnosis, treatment goals, treatment indications, the treatment of the monoinfection, HCC surveillance, treatment in special patient population like acute hepatitis B, patients with co-infections like hepatitis delta, hepatitis C co-infections. You know, Delta is a guideline. We have a new recommendation in this, so an update of the Delta guideline for one special topic. We have transplantation included. Then a big topic is prophylaxis of HBV reactivation, very important for clinical practice, management of HBV in the setting of transplantation, and as mentioned, the vaccine. And finally, an open question and future direction section where we also talk about the nomenclature. We may discuss this at the end. Now, for treatment indication, I think this is the hot topic where there is some differences also between among the different guidelines. And I think this is a statement, first of all, that in principle, all S antigen positive individuals with detectable HBV DNA are in principle candidates for antiviral therapy. It's an infectious disease. If there's virus detectable, we want to get rid of the virus in principle. However, as we know, the evidence for certain subgroups is not very strong, and we still should stick to some level of evidence, not to get over treatments. And therefore, the indication for treatment is primarily based on HBV DNA, where we know higher the worse. ALT levels, sure, patients with hepatitis have a strong recommendation to be treated. Fibrosis stage, risk of liver disease progression, HCC. I will fine-tune this now in the next couple of minutes. And for simplification, we try to merge all the very sophisticated recommendation which we have in the guidelines into one algorithm, into one figure. Here, the strength of the recommendation is not covered in this algorithm, and you can see when we start here from the top that HBs antigen positive individuals like chronic HBV infection who have an advanced fibrosis defined as a meta-via more than 3. So we also looked at the evidence for fibroscan levels like more than 8 kilopascal or cirrhosis. We recommend to treat patients if HBV DNA is positive, so any level of HBV DNA. If this is not the case, so patients with milder levels of fibrosis, we look still at the HBV DNA. Because those, we called it previously in the past, inactive carriers, so patients, individuals with chronic HBV infection, lower than 2,000, there is no ALT elevation, so we consider this is a group of individuals that do not require immediate treatment, that can be monitored, and if something is changing, we can treat. If the HBV DNA is more than 2,000, we have a lot of reasons to treat. Yeah, of course, if there's hepatitis, if there's fibrosis, if there's a risk for HCC, we provide a table with many risk factors for hepatocellular carcinoma, extrahepatic manifestations, immunosuppression, risk for HBV transmission. We want to set the bar very low to start treatment, not to forget or to oversee that patients are left untreated. I think that is important for the cascade of care. Sure, there may be some individuals in this setting where there is not so much evidence if an antiviral treatment really would change something and the outcome. That is for sure, and we may discuss this. So these are the special recommendations behind this algorithm, which can be found in the text, where we really differentiate between strong recommendation with a strong consensus, or where we have weak recommendations, but still reached a strong consensus. For example, the evidence for advanced liver disease or for advanced fibrosis with any detectable HBV DNA is weak. We don't have data like this. Even here, we have contradictory data. There are some data from for example, from Korea, that patients with cirrhosis with levels below 2,000, that this is not such a different outcome if you treat or not treat, or if the patients are low level of viremia or undetectable. So there is controversy in the data, but still we feel the patient with cirrhosis needs treatment with any level of viremia. Therefore, we achieved here a strong consensus, although the evidence level is only 3. And you can see the evidence level is even lower. So we differentiate this, and the expert may look at this also to consider in this situation, if there is any reason the patient is hesitant maybe to be treated or so, to have also arguments, maybe we can wait, we can monitor, but we have on the other side also arguments to treat. So I think this is very important. We come to the point of shared decision-making in a minute. Just a moment. So the next point is, of course, those individuals that are E-negative with a chronic infection, with low level of viremia, persistently normal ALT, no signs of liver fibrosis, and there is clearly not an evidence if those patients require really treatment. I mean, they have a low risk of disease progression. We have a lot of data for this, and usually they do not require immediate antiviral treatment. There's a strong consensus. We made it a statement, not a recommendation. there can be always reasons to treat someone. I mean, you know that there is fluctuations of ALT, and if someone is in uncertainty, we have these individuals that may have low level of viremia. There's still maybe comorbidities like a muscle D or some other issues where you may think you want to get some level of confidence that we do not oversee something. That is all in the text, in the commentary. And this is, of course, also a topic of controversy, that if you have patients with persistently low HBV DNA and persistently elevated ALT, how to deal with this. I think the first issue, you need to exclude other reasons for liver disease. There can be muscle D, there can be co-infections, there can be a rare liver disease whatsoever. I think that needs to be excluded. And in most cases, HBV is not the reason for this. But still, we consider with a low level of evidence a B recommendation, and we found a consensus, not a strong consensus, that there is a weak recommendation that these patients can be treated. Maybe to be sure that this is not the reason, we have to find something else which is important to look at, like maybe a rare liver disease, and to maybe even to test for genetics or whatsoever. I think that it's very important. And then we have, of course, the issue of patients who have an hepatitis. There's a strong recommendation. I think we can skip this very fast. This is very clear and straightforward and nothing different to the previous recommendations. Now, an issue is, of course, and maybe Patrick will talk more in detail about this, the young individuals, so-called in other guidelines and also previously immune-tolerant patients. We don't want to call them immune-tolerant because we think there are immune responses. And the wording of immune tolerance is, I think, not appropriate for these individuals. We will call them young individuals with E-antigen-positive chronic HBV infection. And we define them as persistently normal ALT, no significant liver fibrosis, no family history of HCC. This is important. No immunosuppressive conditions. Current clinical evidence does not support immediate antiviral treatment. We may see some data in the future. Therefore, we left it also open because we have this theoretical evidence. There is a potential benefit of early therapy, such as reducing HBV DNA integration, clonal expansion, and this should be balanced against the strict need for adherence, especially in the young individuals. Yeah, if you start a treatment, you need to continue. I think we have all seen that patients do not take their medication, are not adherent, they can relapse. This will be very, very dangerous in young individuals with E-antigen-positive chronic infection if they go down with a viral load, do not take their medication anymore, and so on. Therefore, this is important to discuss with the patient, with the individuals, and we need long-term daily treatment. And it is also difficult to achieve a rapid and complete viral suppression in those individuals with very high viral load. Therefore, I think we need shared decision-making. This is an important point, and I think we made this comment in the comments in the text, in the accompanying text of the guidelines, that there is this important open discussion about the benefits and limitation of therapy. And I think if we will in the future achieve a treatment or get to a treatment that achieves functional cure in the majority of our patients with short treatments, I think we don't need to discuss it anymore. But at this stage, I think this is still important to discuss. So the E-antigen-positive chronic infection, of course, there are other reasons to treat. And one is, of course, if there is a risk for HCC, family history of HCC. Therefore, we explicitly say this, and we have also a table in the guidelines to look at all these risk factors that may be associated with HCC risk. And then, of course, we have a reason to treat those patients immediately. Extrahepatic manifestations, clear, is an indication. Immunosuppression is a treatment indication that is clear. But also we make a statement, we make a weak recommendation that selected individuals with E-positive chronic infection can be treated to prevent HBV transmission. Sure, I mean, especially, of course, if this is required in medical, for medical doctors or staff like nurses and so on. But for everyone who seeks treatment and is concerned about transmission, there is a reason to treat someone to prevent transmission of the virus, especially in those individuals with very high viral load. And this is particularly of importance for the pregnant woman with HBV DNA more than 200,000, because we know that we can prevent vertical transmission, mother-to-child transmission, if we treat pregnant women if they have high viral load in this situation. This is clear. This is a strong recommendation. We have a high level of evidence for this. This is a table. I want to just mention this, and you can look it up in the guidelines, where we have several reasons, where there are reasons for or risk factors for hepatocellular carcinoma development. Some of them are controversial. We discuss this, like MUSCLE-D, for example, itself. The data is conflicting, but if there are more and more factors like diabetes and other metabolic factors, then we have an increasing risk. And of course, aflatoxin air pollution is also included. We discussed this. So now to the E-negative chronic HBV infection. This is also, of course, discussed. I mentioned that the patients or the individuals with low levels of viremia, they do not need immediate treatment, but what about those who may have a risk for cancer? And also that reflects to the table. Of course, we have here reasons also to treat chronic HBV infection in patients who are HBe antigen negative, similar to the E-positive situation. I will not go into detail at this stage, but you can see we open up and we lower the barrier to treat patients, and we want to avoid this term gray zone and intermediate phase in the guideline. And therefore, this is one of my ideas, to have kind of a very simple idea of a guideline for treatment indication that fits kind of a beer mat or beer coaster, to have this algorithm here, and maybe on the back the table of the HCC risk factors, and that someone who screens individuals for HBs antigen, and if a patient is positive and has evidence for chronic HBV infection, what is required, and then to have an idea if this patient requires immediate treatment or can be monitored. I think that is the idea here behind this beer mat, to simplify really and get a improved access to or improve the cascade of care. Another beer mat is maybe on stopping therapy. I think I'm at the end now and my time is over. But one important issue also, which is maybe different to also the ASD guideline, that we discuss in a personalized approach, stopping nuke therapy. On one side, of course, we want to lower the bar to start treatment, but on the other side, also for the experts, and there we make it very clear that stopping therapy is something for the expert. Yeah, consult an expert if stopping nuke treatment is considered. We have the evidence for individuals with low levels of HBs antigen in the Asian population, lower than 100, as mentioned here on the back side of this beer mat, and for the Caucasians, lower than 1,000. There is evidence now, even from randomized trials from the German study, that if you stop, you can achieve more often HBs antigen loss. That is the ultimate treatment goal, what we want to achieve in the end. And therefore, we dedicate this section. We have a dedicated section in the guidelines on stopping therapy, but you can see it is something for the experts. And then you have also this algorithm for the E-positive individuals and for the E-negative individuals. We can discuss this. So I think my time is up, and this is what I wanted to say. So I think we developed a very comprehensive guideline on many, many topics. Here I just discussed the treatment indication, but there's many more issues to be discussed, I think, and this is what I wanted to say in my talk. Thank you.
Great. Thank you so much, Dr. Kornberg. That was very helpful. We did get a few questions in the chat, so we'll be sure to direct those to you once we move to the Q&A section. But at this time, I'd like to now pass it over to our panelists. And Dr. Su Wang, who will be starting off the panel. Over to you, Dr. Wang.
You're on mute.
Yes, I just noticed that. Thank you. Thank you for having me. And this is such a great session. I'm just so happy to see so many people here. I'm going to be speaking about the view from the patient perspective. And I am somebody living with hepatitis B. I'm also a clinician who sees people with Hep B, and I was honored to be part of the Delphi panel that Marcus mentioned for the EASL guidelines. So I want to shift this to kind of looking at what is the role of people living with hepatitis B. And so I've got some slides just for us to put some context into community perspective and putting a center stage of people living with Hep B. And so, what do people living with Hep B think about treatment? I'm sure we have lots of input here in the audience. It looks like a lot of people who are affected by hepatitis B here. And, sometimes it's not as simple as what are your test results, right? We know there's so many dimensions and challenges people with Hep B in terms of access to medication, as you see here, testing, whether they're getting testing or not. You see here, and these are all quotes from people living with Hep B. People talk about how they get lost to care, they get tested, do they have access to testing, and whether if they don't get tested, they're not identified, and we're not even having this conversation about whether they're getting treated. Whether they have access to healthcare workers or doctors who are knowledgeable about Hep B can be a barrier. And finally, about treatment, right? Treatment guidelines. So these quotes here say, I think most at times, some clients are told per their test results, they don't need treatment. And I was thinking, why not start treatment earlier to prevent the stage where the case is serious? And this person says, I like for treatment guidelines and algorithms to be simplified to test and treat. Also, health insurance should cover for treatment. So these are just some thoughts, obviously not very comprehensive. I want to direct everybody to a statement that me and Danjuma Atta, who was the president of the World Hepatitis Alliance, made a couple years ago. This is a declaration from people living with Hep B, which is a real call for a whole person approach. And I just want to read this one paragraph that says, we as people living with Hep B want whole person care, not just care that's focused on our liver. We want our doctors to consider the overall impact of Hep B on our whole lives and consider outcomes which are important to us. So we don't want to worry about living with, about developing liver cancer or spreading the infection because of our inability to access care and treatment. And we want flexibility in the treatment recommendations so that we can receive care and treatment, even if we are resource limited and diagnostic testing is not accessible. We want simplified treatment strategies so that care is available to more of us. And we want to be at the center of decision-making for our care with our preferences and values prioritized. So I love what the EASL guidelines have done in terms of really putting shared decision-making at center stage. And then now we're going to talk about how patients have been involved with guidelines, and in general, why we think patients should just be more than subjects at the bottom, just participating in studies or getting care. But we really should think about being more engaged to the point where we're actually involved with researchers and scientists to plan, design, and come up with guidelines as we're talking about today. I'm going to bring in Thomas real quick to talk about a paper that he wrote with a number of other co-authors, just talking about what are some best practices for engaging communities and some points that come from that I think are really relevant with how we design guidelines as well. Thomas?
Yeah, thanks, Sue. We were part of a sort of consensus statement on our own, talking about how best to engage with people living with hepatitis B. So myself being representing Hepatitis B Voices Australia, so we led this discussion with a lot of community groups around the world to figure out how best, given everyone else's experiences in talking with the sector, what practices work best and what didn't. So this is an open access paper. People will get this a link to this paper in the chat. But essentially, it boils down to two major key points. I won't go through the principles, the 13 principles we came up here, but really concentrate on the two main key points, which is that lived experience is expertise, and so it should be used, and it should be recognized as expertise. So that means that people, when the sector or the professional community gets involved and starts this conversation, they should know that this is actually work. It isn't just something that people with lived experience participate in, but they are experts in their own right. And the second major thing is that this process should be iterative and it should be a sustainable practice. And that means making sure that people are okay with these interactions, but also making sure that it's supported, going through a lot of the established organizations that have been set up, and also making sure that the support is there afterwards through this work that includes emotional support, trauma-informed practices, and making sure that there's debriefing afterwards to make sure that people know what kind of impacts they have made during these sorts of discussions. So thanks, Sue.
Right. Thanks, Thomas. This is very helpful. I want to acknowledge Sherry was senior author on this paper and has been a big part of these discussions too. So moving on. Okay, so I want to take a step back, and I think people realize we're in the middle of this like flux of Hep B guideline updates, which is very exciting for us, and a number of us have been involved with a lot of them. We think community inclusion has been really important and is critical for us to continue to develop these guidelines in a way that is person-centered and patient-centered. So a number of us were involved with the WHO guidelines that came out last year. So me, Sherry, and then Catherine was a part of both the guideline development group or the preference and values work group, where from every WHO region, we had people represented on the guideline group, also on the external review group. And then separately, there was a preferences group that came together to find evidence on patient values and preferences for treatment, and also providers. And I'll share a little bit about that. And then now the EASL guidelines came out in May. There were 2 patient representatives, me and another person from Europe. The Canadian guidelines came out at around the same time. They had 1 co-author from Action Hepatitis Canada who was represented. They did have a review, although there wasn't a Hep B specific person living with Hep B who was represented. And then the American guidelines, the AASLD guidelines, are forthcoming. And that writing group had 1 patient and then 1 patient/physician, who was me. And then the APOSL guidelines are in progress. So we've got a lot to kind of look forward to, and I think we should continue these discussions, as these guidelines come out. So this was a survey that Hep B Foundation did. This is for WHO guidelines, but it's really interesting in terms of finding out what people think. It was really widely represented. And I'm just going to cut to the chase and just focus on 3 questions and answers that I thought were really interesting. One was, did any of your healthcare providers explain there were choices in what you could do to treat hepatitis B? It's remarkable that almost 50% of patients said no, that their physician did not even bring up to them that they had options for treatment. So this is something important for us as physicians. I think we often think, of course, I do shared decision-making, I talk to my patients, but when you ask the patients, sometimes we've already decided to them that they didn't need treatment. So this is important. Second, did any of your healthcare providers ask if you wanted to start treatment? 43% yes, 50% said no. So patients were not even asked if they were interested in treatment. And then lastly, do you want your healthcare provider to ask you to be involved in choices around hepatitis B management and treatment? And the vast majority, 85%, said yes. And I have to say, as a physician, after I saw the survey, I started really thinking and changing how I do things and making sure it's really clear when I talk to a patient that I'm presenting them options, asking if they want to start treatment. And I think this is something that is a message that's growing in the hepatitis B space. So in terms of WHO, how did this get incorporated? I think it's still very lab-based. There's a lot of other co-infections and things that can, or if you have MASLD or diabetes, you can be eligible for treatment. But there is small area where it does say that we can have a patient-centered approach to discuss between healthcare providers and the patients if there's additional reasons to be treated, such as transmission risks, stigma, if somebody's really concerned about Hep B integration, as Marcus was mentioning, in terms of oncogenicity, like, in terms of preventing cancer. So now shifting to EASL, this is the process that Marcus discussed in the Delphi group, had 2 patient representatives out, as I was mentioning. And what is really different, I think, for the EASL guidelines that has not been in the other guidelines is the mention of patient-reported outcome and HRQOL, which is quality of life indicators, as a goal of treatment. So I don't know if you all caught that, but now the goal of treatment is not just preventing liver cancer, cirrhosis, normalizing your lab values, but we actually want to improve patient-reported outcomes and quality of life. So what is that? A lot of people, have not really heard about that. So this is recognizing that our understanding of Hep B disease is incomplete without the patient experience. This is a way of systematically measuring that patient experience. So we're not just looking at your lab tests, but we should be looking at how a patient feels about having hepatitis B. Are there other symptoms that we don't assess while we're in, just looking at your lab test? So PROs, patient-reported income. So any report of the status of a patient's health condition that comes straight from the patient without interpretation of the response by a clinician or anyone else. So you may just say, I feel fatigue, I just don't feel great. That counts. Health-related quality of life is a type of PRO, and that measures the experience of the Hep B in the patient in health domains. So PRO could include stigma or worry or, feeling discriminated. Health HRQL is more focused on the health aspect. So all this shows us that, we're seeing more and more data showing that chronic Hep B is not a silent disease, as it has often been labeled. Even clinically, we often find that when liver tests are normal, if you were to do a biopsy of the liver, sometimes there is inflammation, even when there's a normal ALT. And then experientially, patients often can have symptoms even if their labs are normal. So PRO HRQL can help us measure disease impact. We think it can even go further. It can help us decide whether patients should be treated, help us understand as a physician how Hep B is impacting a patient's life. Oftentimes they don't tell us the things that are really bothering them. And Thomas and Sherry, who were all part of the hepbcommunity.org forum, you will see patients have a lot of worry, and that ends up a lot in those messages. And I encourage you to check out the website, because these are things that they never tell their doctor, but really do bother them. And so this is extremely important to acknowledge that. So this is a survey done by the Hep B Foundation. What are some benefits that patients report of taking medications? So patients say the value of me taking medicine. This was very surprising. The number one thing in the US was actually not worrying about transmitting the virus. So you can see liver cancer is further down, at least in the US. And not having to avoid others was the number one cause for people outside of the US. So these are things that are not, quantifiable by lab tests, but definitely these are the priorities for patients. This is talking about HRQL. This was another study kind of looking at what are some other domains, besides physical domain, what are some other domains that are affected by having Hep B? And so we were able to pick out its physical impact, but there's also social impact, where stigma, shame are captured, and then worry impact. Like, I'm just worried that I'm going to give the virus to somebody else. I'm worried I'm going to develop liver cancer. These were pretty significant. So just in closing and as a launching point, we know Hep B has a lot of effect. And the question is whether antiviral treatment has a role in this, or whether it can help improve HRQOL and PRO. And this is something we need to study more. And I think the EASL guidelines are a really great step into incorporating that. And we look forward to kind of seeing how this plays out. And I'd love to hear what my co-panelists think, Sherry and Thomas, in terms of this.
Thank you so much, Sue. I appreciate you bringing up all of these key points. And one of the things I think you really honed in on is that the patient, the experiences and the preference and even the goals of people living with hepatitis B in terms of treatment are not always the same as the providers, right? So providers have very specific goals in their minds when they're thinking about whether to treat and how to treat. And those are not necessarily shared goals. And I think the idea of bringing in shared decision making then prompts us in the, people in the provider and clinical space to say, how can we make that happen? And as you mentioned, documenting, asking questions like what is important, right? And I think the really important thing to think about is we have these QOL instruments that we can use. There are at least 2 or 3 short surveys, one which is the HBQOL. It's been out for about 15 years. It is very specific to hepatitis B, and clinicians who don't have to think of the questions to ask. You can actually just use this instrument, and it will help patients at the table with clinicians to share the things that are important to them and the impact that living with hepatitis B has on them. And that can be used in the shared decision-making process to help make shared decision-making sort of less amorphous and more rigorous. And I think that's really important. I also just want to say how things have changed, how this space has changed. I don't think we would have had this conversation 10 years ago, 5 years ago, maybe 15 years ago, definitely not. The fact that we are even talking about shared decision making, the fact that we have seen different ways of integrating the perspectives of people living with hepatitis B into guidelines is incredibly gratifying to see. I hope we can see more. I will say that the working in the WHO, working with the WHO guidelines, being able to rigorously collect data from people living with hepatitis B and providers around the world, and then using that data to actually inform the guidelines, that was ideal. But I understand it's not always easy to do with all of the guidelines committees. I think we're making great progress. There's a lot of work to go, but the fact that we're having the conversation is a step in the right direction.
Yeah, I agree, Shari. And just to pick up on that point, I feel like we should make sure that we continue to develop the patient voice or the community voices. I mean, it's great having Sue on these panels, but you and I, Sue, I for all of those out there, I also live with hepatitis B. You and I are not necessarily representative of the entire community. We can't be all 300 million people around the world and represent them all. So I think making sure that we understand what is actually happening in the community and being able to funnel that into these boards and discussions are most key, rather than a select few people living with hepatitis B. And that's what we're of course endeavoring to do, but this is great progress.
Great. Thank you so much. And thanks to our panelists for providing this insight into the lived experience and the implications for that, for the guidelines. Any final thoughts from the panelists regarding the progress made or future direction that you see moving forward related to guideline development?
Yeah, I think again, picking up on my point, to get more of this conversation happening, there needs to be a bit more of an accessible version of these guidelines to make sure that everyone is part and understands what it has been established in this master document. This should be a sort of template for providing more accessible versions so that people who for which this 100 or so page document can be really more easily digested and understood, means that more people can provide their input through Hep B Foundation or any of these other existing community organizations to be able to make sure that their voices are heard.
Yeah, Thomas, I agree with you. Marcus, I love the beer mat, the beer mat / coaster idea. I think that's great. And what an incredible way to disseminate, especially to clinicians around the world for whom, hepatitis B might only be a small part of their practice. I think too, Thomas, we can continue to create sort of those simplified versions that are for the community. We did it for the EASL for the WHO guidelines when they came out. We have a one-pager. It's basically check boxes, right? And we can certainly do that. And I think it's on us in the public health space and in the community engagement space where we can kind of lift up the community so that they can have those conversations meaningfully. The last thing I wanted to just briefly touch on is the question of adherence, because I do know that there's a lot of conversation about, concern about adherence in terms of initiating treatment for hepatitis B. I think that's a really important topic that we need to do a lot more work in. So ICE-HBV we published 2 companion pieces through ICE-HBV. I can put the links afterwards. And adherence is an issue that we need to address. We need to understand really how many people don't adhere to treatment long-term and why there might be an issue with adherence, because the last thing we want is the concern of lack of adherence to be standing in the way of treatment access. I think if we look to other chronic conditions, usually what happens is the guidelines reflect the idea that adherence can be an issue, but then provide support, right? I think the goal is, how do we flip the narrative so that adherence isn't a challenge to treatment, but that we can provide support for adherence to help make treatment happen when necessary. That's it. Thank you.
Thanks so much, Dr. Cohen. Dr. Wang, anything to add to that?
No, I think this is all great. And I think I'm looking forward to Professor Kennedy giving his cases and examples. I think the question is, how do we implement this in real life? So
Definitely. That's great. Well, thanks to all of our panelists for being here. And we may have some questions for you guys when we get to the question section, which will be after Dr. Kennedy's section. But I'll go ahead and welcome Dr. Patrick Kennedy, who's a consultant hepatologist and gastroenterologist. His work on hepatitis B virus is known internationally, and he's widely published in the field of hepatology and was intimately involved in the guideline development. So I'll pass it over to Dr. Kennedy, and you can share your screen as well. So I'll stop sharing mine.
Well, it's a real pleasure to be here. I hope you can hear me and see my screen.
We can hear you. Cannot see the screen just yet.
Let's see the screen.
You can see my slides?
Yeah.
I can see the screen.
Okay.
Good. Okay, well, look, it's a real pleasure to be here. Thank you, Catherine, for the introduction. And it's a real pleasure to be, with working so closely with colleagues on the panel and being part of this. And I'm going to, give a very quick version of these couple of slides, and starting probably with what Chari was just describing, these ICE-HBV papers, which were just published in the last month or so, which are companion papers, which I really think are an important element that we want to focus on and build really on the guidelines that we've had so far. So one of the things to really highlight is, in the chat, people were talking about the test and treat, and what these papers and what this slide really shows you is the burden of chronic hepatitis B, the work we need to do, the really abysmal number of patients who've only been diagnosed with chronic hepatitis B, and the very small numbers of people who've been offered treatment to date. So we have a lot of work as a community, as treating physicians, as people living with chronic hepatitis B, to address these and really change this paradigm. And I think that's something which is really going to be important in the coming years. If we look here, I'm showing you, picking up where Marcus very elegantly talked about the disease phases in chronic hepatitis B, our understanding, what I would say is our better understanding. But if we look at these classical 4 disease phases, starting here on the left with what Marcus referred to as E-antigen-positive chronic infection, people used to refer to as immune tolerant. I remember when we first worked in hepatitis B, this, in inverted commas, diagnosis was based around a HBV DNA and an ALT. But if you look at this figure, what I'm showing you here is the amount of virological markers that we can now include in trying to better understand these disease phases and what they mean, and also data which has emerged from ourselves and others showing that the immune response is really quite well preserved in younger people living with chronic hepatitis B. And in fact, converse to what people used to say to us, this might make it a very good opportunity to offer individuals living with hepatitis B treatment so they may benefit from treatment moving forward. So these classical disease phases continue to exist, and Marcus talked about how we wanted to remove what I would consider unhelpful terms like gray zone, indeterminate, etc., because we can remove those by setting the bar as low as possible to be able to offer people treatment moving forward. And I'm just going to show you this very simple, I often call it probably the kind of most basic or elemental cartoon where we look at host factors and viral factors which are contributing to or risk factors for the development of liver cancer. Now, what's really important here is that if you look at what are modifiable and non-modifiable factors, apart from gender, your family history of liver cancer, where you're born, because this may be associated with some environmental risk for liver disease, there are multiple elements or factors where we can actually address to mitigate the chances for the development of liver cancer. And I think this is really important. So age is one. If we treat people younger, we think we can avoid more liver cancer. If we treat people earlier, we can avoid people with advanced fibrosis or cirrhosis where the risk is greatest. If we treat people with a lower viral load, we can do similar by reducing the risk for the development of liver cancer. And that's where this HBV of 2000 that Marcus referred to in the guidelines is critical. And nobody here needs to be told by me that an elevated ALT is going to increase your risk of inflammation, fibrosis, cirrhosis, and development of liver cancer. So the things which we can't modify are the non-modifiable factors such as HBV genotype and the time it takes for your host immune response to lead to e-antigen seroconversion. But many of these factors we can address, and that's really important. My focus in research in recent years, and Thomas and Mark and others here have been involved in similar work, where really I think what we've looked at in a lot of detail over the last few years in the field is this concept of HBV integration. So that's the integration of the virus into the host, where this in its own right is a risk for the development of liver cancer. Now, we're all very familiar with the concept of a high viral reservoir, cccDNA, pregenomic RNA, the development of inflammation, fibrosis, cirrhosis, and the development of liver cancer. But we also have to consider the fact that integrated HBV DNA into the host is also a source and a very important risk factor for the development of liver cancer. So the obvious question is, what can we do about this? Can offering treatment earlier avert the development of cancer? Can it have an impact on integration? And these are key elements which I think the field and the researchers and clinicians will have to address more in the coming years. And then I wanted to just highlight what I think is really important, and Marcus also referred to that, because in the guidelines we did want to highlight the fact that there are other factors which are at bay, such as coexisting MASLD, alcohol intake, excess weight. All of these factors are really important and need to be considered when we're thinking about making treatment decisions around chronic hepatitis B. Now, just looking at these couple of cases to highlight this, this is an 18-year-old, originally born Vietnam, joined my clinic, found to have be surface antigen positive in ED testing. You will see this 18-year-old female has a viral load of 18 million international units per ml. She's got an ALT of 26 with a quantitative surface antigen of 42,400 IU. Ostensibly no comorbidities, normal kidney function, and a normal median liver stiffness on FibroScan. This is a key example to me of an individual with chronic hepatitis B where the guidelines allow us maybe to change our approach to what we were doing a couple of years ago. So think about it. We are looking at a person who now falls within this very early phase of chronic hepatitis B, that e-antigen positive, high viral load, normal ALT. This person is treatment naive, confirmed family history with an aunt, no family history of HCC. But importantly, from that individual's personal circumstances, about to start their first trimester at university, although they have no partner sexual contacts at present, the questions that we discussed in the clinic were around what would the implications of this diagnosis, what were the implications of having chronic hepatitis B and this level of viremia in the absence of significant overt inflammation or liver damage. What does this individual disclose to friends, housemates, sexual contacts at a key part of their lifetime when they're moving from, into third level education, moving to university? What are the treatment options? And, Sue talked a little bit about this. What are the discussions that we're having with individuals in the clinic in this scenario? And then a very sensible question, what are there curative treatment options which may be at our disposal in the future? Now, my approach to this is all around the shared decision making. What does this individual think about their hepatitis B, their virus, how they will disclose this to their friends, to potential sexual contacts, etc., as we move forward. So really, the decision around treatment here, facilitated by the EASL guidelines, is very much one where I think this would be a shared decision, agreement between the treating physician and the individual. And certainly in my perspective, I would be supporting this individual to have treatment where 5-10 years ago, this was not the case. If we look at another case, again, just to try to illustrate some of the complexities, this is a 39-year-old gentleman in my clinic from Albania in East London. We have a lot of people who come there for work to London, construction industry, etc., referred by his GP with a positive hepatitis B surface antigen test, but no previous medical interactions or treatments in Albania. This individual had not really even seen a GP in Albania. The serology confirmed him to be hepatitis B surface antigen positive, HBeAg-negative, with a viral load of 1,780. Now, importantly, you will see that this viral load is less than 2,000 IU per ml. More broadly, his ALTs were kind of fluctuating, but persistently in the kind of 40 territory, quantitative surface antigen level of 11,280, with a FibroScan of 7.8 kilopascals. This is important because I saw some questions also in the chat about the thresholds of FibroScan. Now, the key question here is this patient, is this individual sitting in the clinic, presenting to a doctor for the first time? What is our approach to treatment? Do we support treatment? Is treatment what we should be thinking about in this specific case? This gentleman is treatment naive. He reports having no comorbidities or no comorbidities reported by his GP, but he does consume alcohol to excess above the recommended allowance for an adult male. Interestingly, he had an uncle who died of liver cancer, but he was unaware whether that uncle also had chronic hepatitis B. This is important. I asked more broadly about his family history, and he said that his grandmother also was unwell. He thought she may have liver or kidney issues. When I asked him in more detail, he said she had repeated hospital admissions, and some of these hospital admissions, they were draining off fluid. Essentially, he was describing his grandmother having decompensated chronic liver disease, attending her local hospital for paracentesis. So this is an individual with a viral load of 2,000 IU, an ALT which could be considered borderline, a FibroScan which may be below the threshold of 8 kilopascals for offering treatment. This individual was unsure about treatment, but there were certainly concerns from my side around this individual's medical history. So essentially, the point I'm making is we need to think beyond the virus, beyond just the liver, beyond even just these disease phases where I've highlighted this individual probably sits somewhere between E-antigen-negative chronic infection and E-antigen-negative chronic hepatitis. But, even these phases, we have to consider that not everybody sits neatly into the phases. We have to consider multi-morbidity. We have to consider family history and that individual circumstances. And in this case, I recommended that this gentleman should start antiviral therapy. And again, he was going to think about this and the time frame of it and when he would do it. So finally, I want to conclude by saying when we started off by saying what were the clinical implications of the EASL guidelines. I think the first thing, which clearly to me is that we will be treating more patients, more people who are living with chronic hepatitis B. I think that is clear, and I think we should be. The second thing is, I talk about putting the individual in the driving seat, giving somebody the information which gives them the informed ability to make decisions. And this is what EASL has suggested. This is the concept of this shared decision making, which I think is really critical as we move forward. I think on a scientific level, we need more studies to confirm the benefits of nuke therapy to reduce the extent of HBV DNA integration, clonal hepatocyte expansion, because this is an important aspect of this. And are we able to really impact what integration may be doing over a 5, 10, 15 or 20-year period? I think expanding the treatment criteria, as the EASL guidelines have clearly done, and I think has been the most progressive guideline today to do this, this will reduce the number of liver cancers and it will reduce the number of complications of chronic hepatitis B. And as a simple physician, when I look at this, I think we expand the number of people that we're diagnosing, we offer more treatment, we lower the bar for treatment. We know that nukes, which are relatively cheap, this can be cost effective, this can be a way of averting the complications of chronic hepatitis B, and moreover, this can be a bridge to functional cure while we put people living with chronic hepatitis B in a safe place until we have curative therapies that we can offer them. And finally, I listened to the discussion about Sue around adherence and others, and some of the work that we've been doing also, I'm very pleased to say, supported by the Hepatitis B Foundation, is the development of this app called Hep B and Me. This is now available to download for free at your app store. I think this is going to be an important tool. I think this will be a tool which will help people as we move forward, healthcare practitioners, people living with chronic hepatitis B. And this is my aim, that we really give the information and put all those individuals in a place that they're in a position to make informed decisions. Thank you very much for your time.
Thank you so much, Dr. Kennedy, for that excellent presentation about the clinical implications and use of the guidelines. That was very informative. We have really reached the top of our hour, and we've done our best to get to all of the questions that have come through, I think, in the chat. Maybe Dr. Kornberg, I know that there's been several that you've answered throughout the chat, but if you had any key points or themes that have emerged from those chat questions that you've answered, that might be good to reiterate. Maybe I'll pass it over to you to do that.
Yeah, one issue is, of course, and Patrick mentioned it also, with the FibroScan cutoffs. Yeah, there was a question, where is the evidence and so on. I mean, the evidence based on the FibroScan cutoffs is based on 2 systematic reviews and meta-analysis, which basically looked at the same studies. The cutoff was also surprisingly lower, as I thought, with 7.5 kilopascal or 7.5 kilo for significant fibrosis and 8 for advanced fibrosis. But I think it's good to have these lower cutoffs, and that really the bar is lower to start treatment. I mean, Patrick, in your case, lower 2000, lower than 8 kilopascal, still ALT was a bit, I mean, we have this weak recommendation that we can treat. I think that is good, yeah, and it's I think also I would also treat this patient because the S antigen is very high. I mean, you may look, I don't know, you must have excluded delta. I always think about delta, yeah, if the S antigen is very high. But you may look at if the ALT is not going down, if there's something else, right? There could be something else, a rare liver disease or whatsoever. Yeah? And I think this is important, that we do not just blindly say everyone needs treatment, and we have still to look at the patient. And if there is something else, you can always have 2 diseases, yeah. And if something is not fitting, in HBV, everything is possible. I always say, yeah? There is nothing you have never seen. We have the strangest situations in Hep B. Yeah? Recently, I saw an E-antigen positive individual with 1,000 HBV DNA, 20 HBs antigen, and was E-antigen positive. I mean, I've never seen this before. Yeah, I mean, this was not on treatment, nothing, and he was 78-year-old. Yeah, so that is so the craziest thing you see. Therefore, I think it's a very interesting disease, and I think this we need still to look at this in a very personalized way, but we need to lower the bar, that we lower the bar not to oversee someone who needs treatment. And then you go, maybe if the patient is some years on treatment, go to the specialist, and then you can consider stopping, right, this issue. Therefore, we have the opportunity in there, and we have all the opportunities in this guideline. And yeah, this is something. So for the FibroScan, of course, FibroScan is not available everywhere. There was also a comment. Question was about FIB4 and APRI. We mentioned this in the guideline, but we do not define cutoffs because there's no evidence for this. The data is very bad for the APRI and FIB4, but still, I mean, we mention also this in the text in terms if you are uncertain, yeah, and if there's a high FIB4, if there's a high APRI, you better treat than not to treat, yeah, and then you may seek expert that have a FibroScan or so. And I mean, this is more relevant, of course, in low-income countries than in Germany or UK, where maybe this the opportunities to get access to FibroScan or other non-invasive measures. Many ultrasound tools have now these kind of opportunities to also measure the elasticity of the liver. So I think that is something we need to work on, but I think that is the data we have. Therefore, we want to keep still the level of the evidence to be also, not to overdo it just to recommend treat everyone with the APRI of more than 0.5. I mean, this is stated in the WHO guideline, but the evidence is not there, I have to say.
Thank you. Just to point out, we did get some specific questions about access to different testing services and platforms. I would recommend, particularly for folks that are based in low and middle income countries, to look at the WHO guidelines, which are more applicable to those settings, and a bit on the simplified level in terms of what is available in those regions. So I would recommend looking at that. Those were updated in 2024. Additionally, if you have individual questions that came through, so we had a lot of folks who personally are living with hepatitis B and had a lot of questions for that. I would recommend, and I put this in the chat, going to info@hepb.org or the hepbcommunity.org to get specific questions answered for your cases. And I'm sorry we weren't able to get to all of those questions. I want to pass it back to our panel from the community side to see if you had any final thoughts or words or reflections from the webinar today.
I think the takeaway, having been part of the process for the EASL guidelines and seeing Marcus had an impossible task of trying to make everybody happy and look at all the data, and there's so many different opinions. But I think he and the group did such a great job, really, and it's very comprehensive what has been done. And I think the takeaway for the community and patients is that within this guideline, there is flexibility. There is a way to navigate this, and there's a lot of data, but there's also a lot of allowance for recognizing that every patient's different. We all have different priorities. There are some patients who really want to be on treatment, and this allows for that. It's better than them being on, herbals that don't work, right? So some people are really afraid of, really concerned about liver cancer, really concerned about transmission, and there is full flexibility, I think, for the EASL guidelines to support that. There are a lot of patients who don't want to be on treatment at all, and there's a lot of data showing based on your lab results, you're okay. But I think, Marcus, you've always said that it's important for the guidelines to be able to say who should be treated strong. There's a lot of strong data versus who can be treated. Like, your data may not be convincing that it's greatly beneficial, but you can be treated if you want to be. And I think that's a really important nuance that has come out of these. Go ahead, Marcus.
I think this is important. Thanks that you mentioned this, because also in the case of Patrick's young 18-year-old female, if you turn it around, I always show the case of an 18-year-old male that liked to party at the weekend and so on. And if he is in this situation, normal ALT, high viral load, of course he can transmit the virus. We have to educate him. But he may not take the medication because he has other things, and we know all this. And I have seen these cases that do not take the medication. They come with flares and so on. So I think this opens up the opportunity. You can treat, but you must not treat. Yeah, and clear if the patient has an hepatitis. I recently had a patient, really hepatitis. She came now for the third, fourth time. She doesn't want treatment, and I have really to convince her, yeah, because she should be treated, yeah, but she doesn't want to get treatment. She wants a herbals or whatever, yeah, and she's, oh no, this is from industry. This is the drugs and the bad industry. Just they want to earn money, and I have to convince her. And this is, I think that is the other side, right? You have also patients that really do not want treatment, and I've seen this, and I think this is so important that you have the situation where you really should treat and where you can treat, yeah, and where you may not treat immediately, in these cases. I think this is important.
Thank you. Thank you for those clarifying points. Dr. Kennedy, any last
Yeah.
thoughts?
Thanks, Catherine. I think look, this has been a fantastic session with really, I mean, insightful ideas and thoughts about where things go. I think the issue, and it's been discussed many times around adherence, I think in some respects that can be a failure of us as the healthcare practitioners, the treating physicians and practitioners. But, you know, that can't be used as a reason not to treat younger people. I think that's the key thing. I think, you know, we need to be in a position where we said we have provided the information, we have educated the community as best we can, and within the community, people educating themselves. I think that's a really key thing. So if adherence is going to be the next obstacle that we need to overcome, I think as the treating practitioners and the community, we need to work together to overcome that. And this is 2025. There are lots of tools at our disposal that should be able to facilitate us to do that.
Thank you. Thank you all so much for being on the webinar today and sharing your insights and experiences related to the updated EASL guidelines. I think this has been really informative, and I hope that you'll take a moment to check out the chat, as we've gotten a lot of compliments regarding today's session, and thanks to all of you for participating in that. To close today's session, I'd like to pass it over to Dr. Sherry Cohen to share and summarize today's session. And we will be sharing the recording of today's session with all registrants following the webinar.
Yeah, thank you. I can keep it brief, but Thomas, I think you came off mute. I wanted to give you a last chance. Are you sure? Okay. Thank you, everyone, for sharing your thoughts today, your expertise, and for joining us. I saw some incredible conversations happening in the chat. And you know, I just want to end with this, Sue and Marcus, what you were just talking about in terms of the nuance. I've been staring at this one question for the past 5 minutes. What do we now do? How do we make sure that providers and patients understand the nuance, that people living with hepatitis B and providers who are treating understand the nuance? Because we have this one question, what do you do if a person doesn't actually meet guidelines but still wants to be treated for one reason or another, and how do you navigate that? And I think the answer is it's going to be different in different parts of the world, and some of it has to do with access and some of it has to do with coverage and expense, but that's where we're going, right? So we're going to have to figure out. I think the great news is we have the nuance and we have the availability for shared decision making. Now we have to figure out the best way to implement it. So stay tuned. We're going to keep working at it, and it's on us now to disseminate and educate and make sure that the key stakeholders know what has to get done next. So we'll keep having the conversations if you all keep showing up. Thank you very much.
Thank you so much. Thanks, everyone, for joining us.
Thank you. Bye-bye.
Bye.
Thanks all.